Hello, my name is Linda Moy, and I am a professor of radiology at the NYU Grossman School of Medicine. I am the discussant for Spotlight Session 11. So let's go ahead and get started. We'll focus on 4 abstracts that are using novel imaging techniques to reduce the number of benign biopsies to predict response to neoadjuvant chemotherapy and to develop imaging biomarkers in patients with triple-negative breast cancer. The first paper is PD11-05, Intelligent Shear-Wave Elastography to Reduce Unnecessary Biopsies in Breast Cancer Diagnosis. It's INSPIRED 002 trial, and it's an international multi-center study. So the motivation for this study is that breast ultrasound identifies mammographically occult carcinomas, but has a high false positive rate. And false positive findings result in additional follow-up exams and benign breast biopsies. In fact, studies show that among all lesions that are biopsied under sonographic guidance, only 7 to 8% of biopsies are found to be cancer. Shear-wave elastography measures the stiffness of a lesion and has been found to improve the ability of ultrasound to discriminate between benign and malignant lesions. So the purpose of the study was to evaluate a machine learning algorithm called Intelligent Shear-Wave Elastography to reduce the number of benign biopsies while maintaining the sensitivity of traditional shear-wave elastography and B-mode ultrasound. This is a prospective multi-center study from 12 sites. They recruited 857 women who each had one BI-RADS4 lesion that was evaluated with conventional B-mode ultrasound and shear-wave elastography. And they used machine learning algorithms that were trained to assess patient, clinical, sonographic, and shear-wave elastographic information to characterize breast masses. And the authors did 2 types of analysis. One was a logistic regression with elastic net penalty, and as well as using a neural network. So they trained and tested their algorithms on data from 11 sites using a 10-fold cross-validation, and the usual performance metrics were assessed. The mean age of the subjects was 49.5 years, and it was a high number of malignant masses, 42.2%. So this is markedly different from the clinical setting in the US. In the external validation set of 285 women, traditional shear-wave elastography showed a significantly higher diagnostic performance compared to conventional B-mode ultrasound, whereas the intelligent shear-wave elastography outperformed both the B-mode ultrasound and the traditional shear-wave elastography. And the neural network showed a significantly higher diagnostic performance compared to logistic regression with the elastic net penalty. And all these you can see were statistically significant. Here is a summary table of the external validation performed in 285 women. And the column on your left here shows the diagnostic performance of B-mode ultrasound. And the next column shows the traditional shear-wave elastography, and then the intelligent shear-wave elastography first with the logistic regression, and then finally with the intelligent net shear-wave elastography using their neural network. And this neural network was able to maintain a sensitivity of 100% while improving its specificity to 53.3%. And the PPV increased from the traditional shear-wave elastography of 50.4% to 61.5%. So to summarize, this is a promising prospective multi-center study that demonstrated that intelligent shear-wave elastography can reduce the number of false positive biopsies by 53% while maintaining the cancer detection rate. And to better understand the performance of this model, we need to know the AUC from the training data set, the development set of 572 patients. As well, we need to know the size of the lesion, especially the benign versus malignant lesions. In most studies, the cancers are much larger than the benign masses. I am interested in seeing the performance of the model with the cases stratified as BI-RADS 4A, 4B, and 4C lesions. As well, what was the effects of clinical age and palpability? This is important because validation set was derived from a single center. Overall, this is a very nice study, and I do hope that a reader study is underway to confirm these results. The second abstract is PD 11-06. It's entitled Radiomics Model Based on an MRI Compilation or MAGIC as Early Predictor of Pathologic Complete Response to Neoadjuvant Systemic Therapy in Triple-Negative Breast Cancer. So the background is that there is an unmet need to develop imaging biomarkers to assess response to neoadjuvant systemic therapy in women with triple-negative breast cancer. Triple-negative breast cancer is a highly heterogeneous disease with variable response to treatments. And the authors here developed a unique MRI radiomics model derived from MAGIC. This is a synthetic sequence that simultaneously quantifies several tissue water properties, including T1, T2 relaxation times, and proton density. And the purpose of this study was to evaluate the ability of a radiomics model extracted from MAGIC sequence to predict PCR to neoadjuvant systemic therapy in women with triple-negative breast cancer. So this is a prospective Artemis trial that included 184 women who were diagnosed with stage 1 through 3 triple-negative breast cancer. Of these women, 146 were scanned with that MAGIC sequence after completing 4 cycles of treatment. So there's a total of 930 features that are going to be extracted from each patient, and that's because there are 310 features derived from each of the MAPs, meaning the T1, T2, and proton density measurements obtained at 3 time points: at baseline, second time point, and time point number 4. And you can see here, this is a patient who after 4 cycles of neoadjuvant therapy, there's still a residual tumor, so this is a partial responder. This is a figure that shows their radiomics pipeline. In A, the MAGIC raw images are obtained from the scanner. In B, the authors extracted T1, T2, and proton density maps, followed by the image segmentation in red. In C, the authors now extract the volume of interest. They perform texture analysis to extract the radiomics features. And in D, they perform a feature selection analysis to acquire the best model fit to predict response versus non-response to treatment. So these are the results. The univariate analysis found that the proton density, T1 and T2 radiomics features obtained after the 4th cycle of treatment was able to predict PCR status with an AUC of more than 70% in both the training and testing cohorts. And the top performing radiomics features were entropy, variance, homogeneity, and energy. And the authors should do a better job explaining what these features mean and whether these top performing radiomics features were expected. The multivariate radiomics model from time point 4, proton density, and the T1 maps from time point 4 showed the best performance during both cross-validation and independent testing. The radiomics signature of the time point 4 T1 map that included 27 features had the best performance with an AUC of 0.77 and 0.70 in a training and testing cohort, respectively. On a time point 4 proton density map, the radiomics signature included 6 features and was able to predict a PCR status with an AUC of 0.73 and 0.72 in a training and testing cohort, respectively. Of note, the multivariate T2-based model did not achieve statistical significance. To summarize, the MAGIC-based radiomic signature could potentially predict pathologic complete response in triple-negative breast cancers early during treatment. And to appreciate the novelty of this radiomics analysis, we need to know some baseline information. What was the performance of the routine breast MRI to assess treatment response? I would like to know more patient-specific data. What were the number of responders versus non-responders? What were the number of patients that had stage 1, 2, or 3 disease? As well, the authors should address the issues of whether there was overfitting, because after all, there were 930 features that were derived from each of these patients. As well, was the performance of T1 better than proton density, better than T2 expected? Overall, this is a very exciting study, and this early work shows the feasibility of using radiomics analysis with their initial work at the 2nd time point, and now with this study at the 4th time point. On that note, let's move to the 3rd abstract, PD 11-07. This abstract is entitled Integrated Model for Early Prediction of Neoadjuvant Systemic Therapy Response in Triple-Negative Breast Cancer. So given the variable response to neoadjuvant chemotherapy in patients with triple-negative breast cancer, the authors sought to develop an integrated model based on imaging, pathological, and clinical data to predict response to neoadjuvant therapy in triple-negative breast cancers early during therapy and after the 2nd cycle of neoadjuvant chemotherapy. And the motivation is that the treatment may be altered if we see early on there's no response to treatment. So the purpose of the study was to develop an integrated model based on imaging, pathological, and clinical data to predict neoadjuvant therapy response in triple-negative breast cancers early during therapy. This is a prospective study of 125 patients with stage 1 through 3 triple-negative breast cancer. And a routine dynamic contrast enhanced breast MRI was performed at baseline as well as post 2 cycles of neoadjuvant therapy, and each patient had to undergo surgery. The tumor volume was calculated using a 3D measurement at baseline and after completion of 2 cycles of treatment. The percent tumor volume reduction, or TVR, was calculated by comparing images obtained at baseline and after completion of 2 cycles of neoadjuvant therapy. They obtained comprehensive demographic, clinical, and pathologic data, including age, T and N stage of the tumor, histology, androgen receptor expression, as well as Ki-67, the stromal tumor infiltrating lymphocyte levels, or TILs, PD-L1 expression, and treatment response at surgery, dichotomizing into complete responders versus non-responders. So among the 125 patients, about half, 61, had PCR, and 64, or 51%, did not have complete response. And the authors had chose a 55% of total tumor volume reduction, or TVR, as the optimal cutoff values for PCR prediction after 2 cycles of neoadjuvant therapy. And so the percent tumor volume reduction, the end stage, and the stromal TILs were associated with PCR in the multivariate analysis. The integrated model containing the percent tumor volume reduction using that 55% as a benchmark, the end stage defined as N0 versus N plus, and the TILs, positive rate of greater than 20% versus less than 20%, was predictive of PCR with an AUC of 0.84. And the integrated model performance was significantly better than a model that only includes the percent tumor volume reduction, or a model that uses clinical data just based upon the TILs in the end stage. So this shows that that tumor volume reduction really does have an effect on improving the performance of the model. So this integrated model that included imaging, clinical, and pathological data showed high accuracy for prediction of neoadjuvant therapy response early during treatment. But aside from reduction in tumor volume, tumor perfusion changes are often seen on MR that may be predictive of complete pathologic response. And these changes in the perfusion are often more pronounced with ultrafast DCE MRI. I'm curious as to whether the authors had a model that evaluated these MR perfusion parameters. As well, was there any difference in patients with multicentric or multifocal disease? The take-home point of this abstract is that the model's performance improves with more input. Now let's go into our last abstract, PD11-08, association of baseline breast MRI metrics and immune infiltration with chemotherapy response in triple-negative breast cancer. So triple-negative breast cancer is a highly heterogeneous tumor, and there's increasing evidence of the role of TILs in this subtype of breast cancer. And robust levels of TILs have been associated with improved disease-free and overall survival rates in triple-negative breast cancers with and without any treatment. So the purpose of this study was to investigate the value of pre-treatment MRI metrics in addition to TILs for the prediction of neoadjuvant chemotherapy response. So this is a retrospective study of 115 women who had stage 1 to 3 triple-negative breast cancer who underwent that baseline MRI and had neoadjuvant chemotherapy from 2005 to 2019. And that the authors routinely performed diffusion-weighted imaging as a part of their dynamic contrast-enhanced MRI. And from the DC MRI, the authors measured the longest diameter of the tumor, as well as documented the T stage. They obtained a number of MRI contrast kinetic measurements that capture the rate of the wash-in and wash-out of the contrast agent gadolinium. The contrast kinetic metrics include a percent enhancement, or PE, at 2 minutes post-contrast, and a signal enhancement ratio, or the SER. The tumor peak enhancement, the PE, and the peak signal enhancement ratios were also calculated. They also looked at the TIL levels between the PCR and the non-PCR groups. As well, the functional tumor volume, the FTV, which is a tumor volume exhibiting greater than 50% enhanced in P at 2 minutes post-contrast, was calculated, and the mean apparent diffusion coefficient, or ADC, was calculated from the diffusion-weighted imaging. So they had 115 patients, and about 40% had achieved PCR. And the pre-treatment TILs were available in 60 patients and ranged from 10 to 80%. The median was 10%, and the TILs were significantly higher in the responders than the non-responders, consistent with the literature. The two blue boxes show that the smaller tumors were associated with response to treatment. PCR patients had significantly shorter diameter and smaller functional tumor volume. The percent PE, or percent enhancement 2 minutes post-contrast, was significantly lower in the PCR group with a P of 0.04, while the SER and ADC, or apparent diffusion coefficient, a measure of diffusion-weighted imaging, were not. So stratifying by stage, both peak percent enhancement 2 minutes post-contrast and the functional tumor volume were predictive of response in T1 and T2 patients, while no imaging metrics reached significance in the T3 and T4 patients. So the study shows in triple-negative breast cancer patients undergoing neoadjuvant chemotherapy, smaller tumor size, higher TIL rates were strongly predictive of response to neoadjuvant chemotherapy. I would like to know the number of patients who had low TIL lesions versus high TIL lesions. And the preliminary results suggest that the baseline peak PE and the FTV were associated with response to neoadjuvant chemotherapy, particularly in patients stage 1 and stage 2 disease. There is a positive literature on this topic, and prior studies showed that the MR kinetic enhancement patterns and shape of the tumor were associated with TIL levels. And I'm interested to see whether the present study supports these findings. In conclusion, there may be a role for MRI and TILs assessment to predict response to neoadjuvant therapy in patients with triple-negative breast cancer. So this concludes this talk. Thank you very much for your kind attention.